use the pointer. Should be.
What I thought I would do is I would try having, as I said, little or no expertise or training or great insight into the actual technology and some of the techniques that are used to obtain some of the extraordinary results that you've seen. I thought I would try to bring us back to two of the more clinical questions that are in. Oh, I'm using this. I'm sorry? Here. No, we're using this one, right?
Yes, but you can use the pointer in your hand. Is it working?
Yeah, it's working.
Also, to change slides as well.
Yeah, that's right. I thought I would bring us back to some of the clinical issues and how to use some of the principles that have been learned over time with regard to interpretation, to regard to understanding of physiology, and try to use this information clinically determined to help us understand some of the pressing needs. While all the technological and monitoring advances that have been proposed here are quite relevant, the fact is we need to build a model that works, and we need to build a model that is efficient, and we need to build a model that solves real problems. Why did it go to the last slide? Anyway. What I'm trying to do is to show you the relationship of insight into electronic fetal monitoring, clinical management of labor, in great measure based upon fetal monitor, and an attempt to help understand two problems. And the two problems are the relationship of cerebral palsy to the events of labor and delivery. And as I've tried to emphasize several times, there would seem to be it would seem that as a statistic to assess the quality of obstetrical care, that you can use the need for emergency operative delivery in a previously normal baby as a measure of the quality of obstetrical care. There can be no benefit, if it can be avoided, to an emergency cesarean section. It introduces chaos, it introduces uncertainty, it increases simply by the need for emergency intervention. It increases the risk of adverse outcome for both mother and baby. So if you can avoid it, it should be avoided. And why not use it as a measure of the quality of obstetrical care? And it differs from most other measures of outcome of care. One, it is a process measurement. Number two, you don't have to wait years to find out whether you're having an impact on the frequency of this intervention. And the problem, of course, is as the cesarean section rate has risen, so has the risk of emergency intervention. Notwithstanding, the fact is that it does not in any way, shape, or form appear to have influenced or benefited the risk of long-term neurologic handicap as measured by CP, stroke, or other parameters. So for the 50 years, or almost 50 years, that fetal monitors have been available, for the vast majority of the time, it has used as a surrogate, or believed to be a surrogate, for the pH. The classification of heart rate patterns by ACOG in 2008 simply says this is a test of asphyxia in the fetus. It makes no mention of behavior and many of the things that we've talked about this time. And they will, as you'll see in a moment, created guidelines for the diagnosis of intrapartum labor-related injury. That really is something they actually made up out of thin air, had no basis in reality fact. But the most important feature, as you will see, it had nothing to do whatsoever with preventability in any specific notion. And the fact is that this focus, this officially sponsored focus on this approach and this understanding of injury during labor has really managed to eclipse information that we should have been getting, information that we should have been using, and methods of management, approaches to management based on these more realistic concepts. There are about 4,000 to 8,000 CP births in the United States a year that we know of. There is no registry of cerebral palsy in the United States. Whatever information we get are those of regional programs. There is no official. It is, I think, something the United States, like some other statistics, does not want to know. The fact is that it occurs in about 6,000 to 8,000 babies a year. Certain babies are certainly at a greater risk, but the major contribution to CP is the term baby, the otherwise normal term baby. That is not to say the risk isn't greater in IUGR, the risk isn't greater in preterm babies, but the numerical contribution to cerebral palsy is simply the greatest contribution comes from previously normal babies at a term. And as I mentioned, the cesarean section rate has not apparently reduced this. The use of fetal monitoring has unquestionably, as pointed out the other day, reduced the risk of stillbirth. It simply does, for all intents and purposes, has been eliminated by the advent of monitoring, and there really is no other plausible explanation for the change over time in the stillbirth rate. The great difference of opinion, depending upon your professional organization, is how much of this is preventable, how much of it is preordained, how much of it is attributable to the events of labor. And I would argue that, as I tried to say the other day, most, but not, as you'll see, most, but not all of CP injury is preventable. Some of it comes on so quickly as that no amount of attention or speed is going to change the outcome. I encourage you all, irrespective of your professional affiliation or credentials, to read this article by Lay. It comes from the British, I think it's British Medical Journal, British OBGYN, and it's The Burden of Cerebral Palsy. And it goes beyond the notion of the premiums for malpractice. It goes beyond the costs of caring for these babies. It deals with the considerable impact on the quality of life, lifelong, and how important prevention is. Here he's going to talk about the costs of prevention with the understanding that there's so much more to this than money. This is the problem. The Green Book, the meconium-laden monograph from ACOG, which was an extraordinarily successful publication because it set out criteria for the relationship of obstetrical care to subsequent neurologic handicap, and said essentially it doesn't happen without these exquisite problems in labor and delivery, which almost no CP baby met. Some do, but most of them don't. Vast majority of babies who are injured during labor, as you'll see, do not meet the criteria that are set out. And since they don't meet these criteria, it must be that cerebral palsy is related to an event other than labor and delivery. The great myth for 15 years, the great myth that if you weren't hopelessly asphyxiated at the time of birth, it did not occur during labor and delivery. These were the essential criteria. You had to have a pH less than this, you had to have an APGAR score less than this, you had to have a specific form of cerebral palsy, and you had to get rid of other identifiable etiologies. You see the trauma. When we came out with the mechanical forces of labor, the new edition of this book excludes the word trauma. They solved the problem of trauma in the interval between the first publication in 2003 and the second publication and in 2014. The fact is that these criteria could only be applied post hoc, that they only applied in terms of the retrospective evaluation. And what they did in 2008, they introduced category 1, 2, and 3, almost as silly as the classification they introduced a little before that, called reassuring and non-reassuring. And the reason for all these classifications is the term fetal distress was not sufficiently specific and lacking specificity. They thought they would change the term. Besides, it was used too often in courtrooms. And so instead of fetal distress, we had reassuring and non-reassuring. And when that didn't work, they went to category 1, 2, and 3. These categorization, which as I've suggested to you, not only makes no physiologic sense, it is not dependent upon an understanding of physiology or fetal responsiveness, and it simply makes, from a physiologic and pathophysiologic standpoint, it makes fetal monitoring unteachable. They had a category called Category 3 that said that was the only category in which you could assume acidosis or from which injury might be inferred. The fact is there is no such distinction, there is no such firewall of heart rate pattern to protect either the physician or the fetus. I want to show you a study that is troubling to me, and perhaps you will find it troubling as well. This is in relationship to the mechanical forces of labor, and this is a very recent study. I think it's 2016 by Grobman. I'm sorry, I'll give you the reference. By Grobman, in which they found a 10-fold increase in the risk of seizures and a 3-fold increase in the risk of hypoxic ischemic encephalopathy by increasing the length of the second stage of labor. So this is the 4 hours, this is less than 60 minutes, and these are the time zones. And here you see seizures and HIE, and over time to a p-value of less than 0.001, the risk of seizures is increased by 10-fold, the risk of HIE is increased by threefold. This is the statement at the end of the article. These data should give healthcare providers confidence that in the significant majority of women, overall outcomes remain good even after prolonged durations of active pushing.
Well, 99% is good for many people. That's the point.
Some of you may not be as comforted as...
Apparently.
Isn't,
You're happy with 1%?
isn't it amazing? Isn't that amazing?
It is a majority, it's 99%.
Well, no, absolutely. There's nothing to be done about it. Let's see, a 1% section, 1% CP rate is 1 in 100. 1 in 100 is 40,000 cerebral palsies a year in the States. Yeah, you're right.
It's down to the individual.
Absolutely right. Well, there's also confusion about what it is, and we are, I suspect, in the unusual time, because I think for the first time, and it's not that there haven't been questions about the value of fetal monitoring, but the questions about what we're doing with it and whether it should in fact survive are actually increasing, and there is a threat, I believe, to the continuity of monitoring as we know it. That's my sense going around and talking to people, that the level at which the questions are being raised are now coming down to operational levels. And part of the problem, as I mentioned the other day, has to do with what is statistical success in terms of the prediction of a bad outcome. The fact is that if you predict a bad outcome, that's one thing. To get a bad outcome is a very different clinical matter. So what we've tried to do with what I'm going to show you is re-engineer that's an unusual term in this setting, is re-engineer the approach to monitoring, which attempts to not only embellish the interpretation of the fetal monitor strip, but in fact take into account clinical features, including maternal condition, obstetrical features, essentially referring to progress in labor, and fetal factors, IUGR and things like that, and put them into a scoring system. This is obviously simply clinical. It is designed with the notion that for it to work in any meaningful way, it has to be implemented in an automatic way, and for such as being used by the people in this room. We have our own traffic light signals, and the basis of the score are really these 8 categories, and the categories are the static categories relating to the mother, the fetus, and the obstetrical issues separate from the fetal monitor, and then the more dynamic issues relate to the use of uterine contractions in terms of what we're going to call excessive uterine activity, whose parameters I will share with you in a moment. And for the most part, these are widely understood risk factors. There's a list of all of them here. The fetus really is simply these related to the fetus, but in fact are just separate from the interpretation. I put it in here, but generally they are separate from the interpretation of the fetal heart rate tracing. For the fetal heart rate tracings, we use standard definitions with a couple of exceptions. The first exception had to do with the use of the designation of excessive uterine activity. 5 contractions in 10 minutes in the second stage of labor is too much, as you'll see, is simply excessive uterine activity. That the European standard of either 4 in 10 or 5 in 7 in 15 is more appealing to us. But there's an even more impressive statistic of relationship of outcome than the frequency of contractions, which I'll get to in a minute. We use something that I borrowed from Diogo and friends called the basal fetal heart rate. That is the establishment of a heart rate at rest at the beginning of the labor, and that heart rate is essentially projected through the rest of the labor, and that is what will determine whether there has been a change. The difference between that basal rate and the baseline rate will determine whether there has been a change in the baseline, and we consider 15 beats per minute to represent a change in the baseline heart rate. And the other thing is we use the recovery of the baseline. So we consider tachycardia either absolute or relative, bradycardia absolute or relative, and the distinction between the baseline rate and the basal rate. Variability, we use the same definitions. I believe, however, that although we use it, I think that 25 beats per minute as a normal baseline is too much variability. And accelerations are distinguished between spontaneous and those related and associated with decelerations in relationship and in relationship to the baseline variability. We take advantage of data and notions that have been performed here. We declare in relationship to recovery. The definition of recovery is, as I mentioned before and previously mentioned, is the return to the previously normal baseline rate and variability. And abnormal or not recovered is prolonged return, progressively rising rate, slow return to the baseline, conversion pattern I've described. And drop data, we use drop data to identify an undefined baby, and we consider that an adverse risk, borrowing from the work of others. We make a distinction between drop data in the first stage of labor and in the second stage of labor. So if there is a deceleration and you cannot define the baseline rate and variability after its deceleration, the baby we consider is unmonitored. It's not drop data, it's unmonitored. It's not a distinction, substantive. It just means that you do not have a handle, and you will see the response that is taken to that information. And then we didn't use it in the actual data we're going to show you, but it is clear we need perhaps a few more colors in there. And one is point A. Point A is the point in time in which the deceleration no longer returns to the previously normal baseline. So it satisfies the criteria of either abnormal or non-recovery of the baseline, And that is a point where we're going to increase and say that you now have to respond immediately, and you need to make this go away or you need to intervene. And that is separate from a difference in the category between the baby who has variable decelerations with the prompt return to baseline features. Point B, which is the diagnosis of injury, and this is used in the first study that we did. Point B is the conversion pattern that I showed you the other day, and this is the point where we're trying to use the fetal monitor tracing to make a neurologic diagnosis. We've tried to make a neurologic diagnosis in the sense of neurologic well-being at the beginning of labor, and now we are trying to make a diagnosis of neurologic injury. It does not tell you about the severity of the injury, but that pattern tells you about the fact of injury and reasonably the approximate timing. And the point of emphasis about point B is that when you've reached point B, the predictive value of point B in now well over 1,000 of these is 1. There's a 1-to-1 relationship essentially between identifiable neurological injury and the presence of this heart rate pattern. Not all of them satisfy category 3. Most of them would be category 3, but as you'll see, it tends to occur earlier than category 3. Here's point A, where the recovery, and you can see that what's happening here after the deceleration, that is not normal variability after, and point B is here, the sudden change in baseline rate, baseline variability, baseline rate. A word about the requirement for excessive uterine activity. It is much more than the frequency of contractions. It is the duration, tone when you have it. When you have an external monitor, we extrapolate based on coupling or prolonged contractions. And when you have the IUPC, it's a baseline tone greater than 20. We measure 2 intervals. The peak-to-peak interval, less than 2 minutes, is abnormal. Interval B is the interval between the end of contraction and the beginning of the next contraction needs to be around a minute. And that says real time, but it should say rest time. And what we found is that is the single most important parameter for the evaluation of in terms of risk. The risk that far more important to us, it seems, and we've shown this, far more important to us is not the frequency of contractions, but the amount of rest time. And rest time is calculated by the absence of pushing or contraction in a arbitrarily 10-minute window, and we require that you have no less than 50% of the time at that baseline of 50%. And we are working on a calculation of rhythm that too often you see patients with overt, flagrant hyperstimulation in which occasionally there are prolonged periods of time between adjacent contractions, 2 or 3 minutes. That is not in any way a mitigator of excessive uterine activity, because what you're dealing with is metaphorically a uterus that temporarily gets tired and then has this pause and then goes back to its increased frequency of contractions. And we're beginning, Larry Oppenheimer did some work on the rhythm of uterine contractions. There's been a question, but that's really what you're after in terms of the effect of either spontaneous labor or, especially with oxytocin, is regular, symmetrical uterine contractions, consistent in amplitude and duration. And if you've gotten that in a regular way, you've probably gotten all you're ever going to get out of oxytocin. And what you can see is here's a baby with no change. This is a baby who maintains stable baseline rate, no variability, has excessive uterine activity, and gets into this red zone. Once again, as I said the other day, I think it is not an appropriate approach to fetal monitoring to say this is a normal heart rate pattern in the face of excessive uterine activity. That cannot be, should not be, and we would not regard it as a normal tracing. So we did two studies. I expected to show you the results of the second, but I just screwed it up, and you'll have to take some of my word for it. We did two studies. The first study involved known babies with cerebral palsy who were normal to start with. And they are normal by, even in retrospect. So all the information about them, about the course of labor, about the subsequent neurologic handicap, subsequent MRI, subsequent follow-up, all identify that the injury occurred during labor, number one, and number two, they were normal to start. Is that clear? That this is the predicate of the study. The predicate of the study is we shall start with we're going to have 50 cerebral palsy babies, all of whom were normal at term, all of whom were normal at the outset of labor, at the outset of fetal monitoring during labor. The second study we did was to attempt to see the behavior of the index in patients who had emergency operative deliveries, and that was either by cesarean section or by vacuum extraction. So in the results of the first study, they had much longer labors. This was, I think we did 250 controls. We're now up to about 1,400 controls. They have longer labors, longer second stage. They have lower 1 and 5 minute APGAR scores. They have lower pHs. The majority of those do not have pHs below 7. And the FRI, as you'll see, varied enormously, was very different compared to the controls. That is, 100% of the study group reached the so-called red zone. They spent far more time in the red zone, and the CP cases spent more than 2 hours in an identifiable what we believe are originally recoverable heart rate pattern. Every one of these babies started with a normal pattern. Every one of them. Only 30% met ACOG's criteria for CP during labor. Only 44% reached category 3 tracing at around the time of point B. This is a graphic display of sampling of controls and a sampling of the CP cases, and the color dispersion, as you can see, is enormously different, and they are all in the red zone for just simply prolonged periods of time. I think one of them was in the red zone for 9 hours of just 9 hours of tracing. And the differences by any measure were just extraordinarily different. This is the amount of time in the hours in the green zone, yellow zone, and the red zone, and you can see that the average time in the red zone of the CP cases was 6.3. These are all the cases. You can see that 65% of them 65% of them had pHs above 7, 35% of them had pH less than 7. The average pH was very different. If you look at the worst color in the first stage, you can see that none of the CP babies got through the first stage of labor with a perfectly normal tracing. And then what you can see, and that by the end they're all in the red. So the monograph criteria identified 30% of the cases. Category 3 would have, at least initially, identified 44% of the cases. The FRI identified 100% of the CP cases and directed, had intervention been applied much earlier in the process in reaching point B. The statistics for, I'm sorry, I don't know what happened to the slides. The statistics are equally significant for the emergency operative deliveries. The amount of time spent in the red zone is much less impressive compared to the CP, is less impressive than the CP cases, but statistically strongly significant. I'm sorry, we now have, as I said, about 1,300 controls, and they just sent me the slides, and I'm not sure what happened with them. What we think we've shown is that there is, in fact, a progression to injury, and this injury, one, takes time, that babies are far more resilient than we sometimes give them credit for, and they can take a fair amount of abuse, but they can't take an unlimited amount of it. And the fact is, you can identify issues that are in fact threatening. And the most common of those in these cases is excessive uterine activity. Far and away, the most important recoverable factor in the origin of these cases of CP are the problems of prolonged labor, excessive uterine activity, malposition, molding, prolonged rupture of membranes, the same factors that have been implicated in HIE, the same factors that have been implicated in perinatal stroke. And there is a sequence, and it is hard to predict the duration of any of these individual sequences. Obviously, there's variation in tolerance, there's variation in the amount of the assault. But if we are here to prevent these outcomes, we're going to have to figure out how to intervene in a non-interventive way earlier in labor. We need to prevent, and we need to safeguard the babies from these assaults. And the question is, when do you intervene? And as I tried to suggest, while everybody would agree on intervening at point C, okay, everybody would agree on intervening at point C. What we're trying to strongly suggest is you want to prevent the problems. The sequence here One, by reducing the number of contractions, by looking at the effect of the uterine contractions and of pushing, and that you long since should have stopped the pushing before this point and see whether the baby can recover. It is like recovery would seem to be likely at this point. Recovery is entirely problematic at this point. And so you need to avoid being in this situation. And this situation of this bradycardia or injury usually occurs at the end of a reasonably long sequence during which there is enormous opportunity for correction of the problem, relieving the amount of stress. And so that once you get into the red zone, okay, the more likely you are more likely to be injured the earlier you get into the red zone. And as I said, all the CP cases were in the end zone. Reaching the red zone is not a criteria for intervention in the sense of delivery. It is a criteria for modifying what has been now identified as reasonably as modifiable facts. You cannot modify the risk factors related to mother, fetus, mother and fetus, but you can modify the risk factors of labor, of contractions, and of response to the heart rate. And so what it means is you need a pair of enlightened eyes, and you need to, as suggested, start a shot clock, and you've got to make the patterns go away if you can, and recover the tracing and keep the baby out of harm's way. We've introduced a term called heuristic pushing, and it suggests that you begin pushing with the urge. It's not contemporary obstetrics as you pushing with the discovery of full dilatation, which most primitive tribes would find strange. But the fact is, you push with every other contraction. If there is prompt return, if there are decelerations, you push with every other contraction, or every third. If there is, irrespective of decelerations, you keep pushing. If there is prompt return to previously normal baseline rate and variability. You discontinue pushing temporarily if decelerations persist beyond the end of the contraction, baseline rate and variability are now indeterminate, baseline rate is either rising or falling, and variability is either decreasing or increasing. You simply stop the added impact of pushing until the fetus has recovered. I would like to share with you, I've suggested it to some of you. If you take, most of you are familiar with something called the dive reflex. Dive reflex is when you hit cold water or the phone calls, or the phone, sorry about that. When your face hits the cold water, your heart rate goes down, you centralize the circulation, you get this bradycardia, your blood pressure goes up. The question is, when does the dive reflex occur in a trained diver? Does the dive reflex occur in anticipation of going into the water, when you first hit the water, or at some arbitrary time after you hit the water? In the trained diver, the response is anticipatory. That is, by the time the trained diver has hit the water, he is already in the dive reflex. It makes no sense to initiate a protective reflex at some arbitrary time after you've been in water. There's a fascinating experiment in underwater, in diving seals, about anticipatory diving. if the seal knows it's going for a long dive, or the seal is cut off during the dive, expecting to return. The fact is we have to translate those anticipatory reflexes to clinical management, and we have to start anticipating the issues of deterioration deterioration of the fetus using the information we've got. So we think we've shown the potential for anticipating certainly and preventing many cases of cerebral palsy. We think we've shown a technique for avoiding what is potentially chaotic, increasingly risky behavior of resorting to rescue, whether by cesarean section or by operative delivery. It should not, we believe, increase the cesarean section, but that's not the primary objective. The primary objective is to decrease adverse outcomes, enhance outcome satisfaction, with the notion that the better the outcome, the less risk there is of lawsuits. That's our conclusions about the value of this essentially clinically determined, clinically evaluated set of records. And the records, I admit, are unique. We have a great deal of the number of these CP cases, and we can get 50 of them, for example, rather easily, that begin with perfectly normal tracings, and even in retrospect were not injured prior to the onset of labor. I thank my colleagues in this study, Dr. Evans Eden and David Britt, and I thank you all for your attention, and it is time for a change. Thank you very much.
Thank you, Rick. So, yep.
Perfect talk, Rick. Three questions about. One is, do you, anywhere in the fetal reserve index, do you consider the presence or absence of meconium?
Meconium, yes. Meconium is a fetal risk factor. It is, yes or no? Yes or no? Yeah.
The second question I have is, you're talking about CP, then there's HIE, and then there's perinatal stroke. You alluded to that at the end of the talk. And I was wondering if you have data or are in the process of data looking at HIE separate from perinatal stroke or combined with perinatal stroke as opposed to just CP.
At some risk, I'm going to suggest that the distinction between HIE and stroke is an artificial one. They, as I tried to say the other day, they share a number of common risk factors for both. We can show you a number of strokes, and strokes look just like those at that point B, the conversion pattern. We think there is essentially very little distinction to be made between HIE and what people call stroke. If you explore this below the minimal surface, you probably, as I did, I suspect you did too, say that when these neuroradiologists are talking about stroke, they're talking about a pie-shaped wedge of brain tissue. Well, that's not what they're talking about. They're talking about strokes that are 25% bilateral, 45 or 50% have other lesions elsewhere, and you run it, and look up Volpe. I mean, and you go in and you say, why can't you get this straight? And you make our lives easier. But the fact is, increasingly, it seems that HIE stroke need not be differentiated because there are different forms of HIE. If you ask any neuroradiologist, can you determine the pH of the umbilical cord from the neuroradiologic exam? The answer is no. Question?
Sorry if I missed it because I was out for a second. What are the risk factors that go in the FRI?
The FRI is an attempt to identify, to answer certain questions that the clinician faces. And those questions are, and this would be for those of you who are doing databases in obstetrical data, I think relevant. Sorry. The relevant questions are, is there anything I have to do for the mother? This is what the obstetrician is. Is there something I have to do for the mother? Is there something I have to do for the baby? The third question is, what is the feasibility of safe vaginal delivery? This is obstetrical care. For those of you involved in making databases, please keep those three separate. Each one of them is a box unto its own. If you classify indications for cesarean section, it is not what is your indication for cesarean section, but was the mother an indication, was the fetus an indication, was the labor an indication, were twins an indication, was infection an indication, which one was leaning on you the most, and how fast did you want to do it. At that point, you will understand indications properly, and you will understand urgency, and ultimately you will understand behavior.
Thank you very much. I agree. What risk factors are in the FRI?
Oh, I'll give you the list.
Yeah, can you, because I got the paper right, but it's not very clear. So you've got a table here that tells the risk, because that's very relevant to me, and if you came to my talk, you would know.
No, we're happy to use
Can I ask
anybody's.
you a question? So there's table 1 in the paper. Are these the risk factors that go, so you've separated maternal, obstetric, and fetal risk factors?
Right.
I think this is very, very important.
Right,
Very
yes.
important. What risk factors? Because one thing is talking about risk factors, one thing is pinning down, which ones do you think are most important? So this table, is this the risk factors that go in the eventual FRI?
Yes,
So all of them go in. So
Yes.
there is like one of them you tick about.
yes.
But so here you've got, so do you have any information how many of these 50 cases? It's not very clear, your cases, right?
Right.
The CT babies, the sicknesses, where did they come from? Is there any bias in their selection? How many of them had, because here you've got placental and cord, anomalous rupture of membranes, you've got abruption, right? So how many of these actually
We
have
can
something like-
provide the details of risk, we give you a map of the risk factors versus the risk factors
Yeah.
versus and the individual cases. I'm happy to
Yes, no,
provide that.
but do you see what I mean? If 45 out of these 50 were cases that had abruption, then of course you've got 100%.
Well, what I didn't talk
Did you write
about,
the
what I did not talk about is, as in many situations, the FRI disappears, is no longer used if there would be an abruption, for example, with a bradycardia. The FRI is terminated, the delivery is effective. But what I'm trying to show you is that irrespective of the risk factors, there is 6 hours, an average of 6 hours between the time of entry into the red zone and the time of injury. I'm more than happy to provide, but I can assure you that they don't have abruption. But the issue of abruption is an interesting one, because when you're dealing with excessive uterine activity, you don't know that you don't. And it is interesting, some of these cases, they keep finding bloody show, and they just keep saying it's bloody show. Well, 12 hours into labor, you should not be having bloody show anymore, and you're probably seeing some degree of abruption. But the question is whether or not the use of oxytocin induces abruption. But a florid abruption would not be there because that would terminate the pregnancy.
Okay, Costume?
Question?
Yeah, Barry, that was a masterful handling of what is clearly a very difficult subject. But just to pick up on Antonia's point, do you feel that all the risk factors are equivalent in terms of the importance of the features? And if, okay, well, I'll let you go.
What has happened is that irrespective of the risk factors that are present, the clinical decision was made to allow labor. If you take that one step further, the expectation was for vaginal delivery. Clear?
Unless they were waiting for theater.
What?
Unless they were waiting for theater.
No. These are, the rules of getting into the study is you are here in anticipation of a trial of labor. This is the only way you got into the study, is that you were part of a trial, anticipated trial of labor, and you would have at least some labor, and that the initial tracing was normal.
Okay, I understand, but later on when abnormality was detected, sometimes immediate intervention is not possible. Right, I mean, that's what we discussed yesterday with Peter Brockenhurst as well, that in some of the cases in the infant trial, it was detected an abnormality. People did want to deliver the baby, but there was no opportunity. I just mentioned that this happens sometimes, right?
As I tried to show in the different slide, the majority of the babies, that is already too late. That is, they have already crossed the threshold of injury, and delay was not. We had the information, but delay was not a significant event. Making the diagnosis was a significant event. And if you want to look at obstetrical statistics, you can find any number of articles in which they calculate the decision to incision interval. Well, that's an issue. The more appropriate interval to know is when the decision should have reasonably been made to the time of delivery. And that is not something that we have spent much time with.
Okay, go back to your point. Sorry, you go back to what
I'm sorry if I'm not answering the question.
It's okay.
No,
The question was for mostly whether you think all the risk factors are equivalent.
those we would have ordinarily, to the extent that there is delay, that a decision was made, we would have taken that into account in an explanation. I assure you that is not a problem for the overwhelming majority of these cases. These are not problems of getting. The biggest problem with availability we find is they decide to do a vacuum delivery with no resources for cesarean section. That is a bigger problem for us, in which they have no option but to pursue the vacuum or add a forceps, because they have no option. They have no accommodations for providing cesarean section should the vacuum fail.
I think Antonia's comment that 99% is pretty good for an outcome. Who cares about the 40,000?
Yeah, right.
And your comment, which is really important, which is this notion like that we have in the United States that there's this 30-minute decision-to-incision rule. That's to protect the doctors. That's number one. Because number two, if you've got a bad abruption, 30 minutes is way too long. Initiated section. You have a prolapsed umbilical cord. It's way too long. Right? You've got an abnormal presentation. You've got shoulders associated. You can't effectively deliver vaginal. 30 minutes is too long. The question is, do you have the resources to intervene with a cesarean section as close to immediately as you can? And so this is why there's a push that never gets properly funded for all sorts of reasons. For regionalization, perinatal care, for real quality infrastructure for an OB to be in process or be in existence 24/7. I mean, I should be able to do the same thing at 4 o'clock on Sunday morning as I do at noon on Tuesday. And I should be able to do that in a small hospital. I should be able to do it in a big hospital. And then if you don't care about the 40,000, then you can deliver them in the middle of the field. That's my take on all this.
So the point I was coming to, I agree with you. If you equilibrated all the risk factors in order to look back in your cohort or your case in your CP pool, but if you were to then apply the fetal reserve index prospectively, do you think you'd be able to apply the fetal reserve index prospectively in managing cases?
Oh, I think we need to keep testing it, of course, but I think the answer is yes. Once you have entered labor, the strongest predictor is in fact what eventually happens with the heart rate pattern and the risk factors associated with it in terms of the duration of labor. That would have to stay, but the risk factors would probably, I'm probably going to disappear. The risk factors will probably disappear, and the issues of excessive uterine activity, change in heart rate pattern are going to. Category B has in the sequential analysis, category B, the tracing of conversion was a 1. So when it was there, it was 100% predicted.
Okay, thank you very much. I think it's time to wrap up the